We'll go on to the next speaker, who is going to be Dr. Deepu George, who is a consultant physician from Medical Trust Hospital. He's going to give us a talk on combining insulin with oral anti-diabetic agents, tailoring the therapy to patients' need. Over to Dr. Deepu.
Chairperson.
And chairperson will be Dr. Paul Puthooran, a senior most physician, who will be handling the question and answers. Thank you.
The opening batsman did very well. Congratulations, Dr. Ramakrishnan. Now the one down batsman is coming. You always remember Virat Kohli. The Virat Kohli is at the podium right now. Give him a big hand. We expect Virat Kohli's performance from you. Over to you.
Thank you, Paul sir, for the kind words of introduction. But I am not going to be batting like Kohli forever. I guess we are almost into IPL, and for anybody who's searching on Google, my favorite team, Chennai Super Kings, is terribly bad. And unlike our API seniors, Dhoni and Jadeja are struggling to push the score ahead. So I'm not going to struggle further with the Kohli style of batting. I guess I'll at least be a Shreyas Iyer from now on. So my topic for the night in front of such an august audience, having been an API secretary myself, it is heartwarming to see Sheetal have a session when almost everybody whom I know among the seniors is here. So that's good news for all of us to start a new year of face-to-face meetings. So after the brilliance of the opening batsman of Virender Sehwag's performance, I guess my fireworks better be short and crisp. I've been given 10 minutes to sum this up, so I'm going to rush through the slides because I don't think an audience which is 90% physicians need major theory classes from somebody like me. So I'm going to look at a pertinent question which my postgraduates asked me is, sir, how do you add oral anti-diabetics to insulin? My answer to that is one single line: you have to tailor the therapy to the patient's need. There's a plethora of OHAs and other medications that you can add with insulin. And let me start by saying that with experience, you will realize that none of the drugs other than insulin have a problem going with insulin. So if you look at the natural history of type 2 diabetes, which Ramashan sir has beautifully said, there is a time when we will be ending up with insulin, or you can start straight away with insulins, because as he rightly said, a lot of our patients come to us with a different question now. Sir, why do you need OHAs? I want insulin. There's a huge set of patients who come to our OPDs and ask for injections as such. And there is a necessity of these multiple injections as the disease progresses. And again, the concern, like Dr. Shamala and Dr. RK said, is the weight gain. So the way forward is a combination of the judicious use of oral antidiabetics, and we can safely establish our glycemic control with reducing the doses of insulin. And another part which I thought we should stress is the rising cost of insulin itself. So it's not cheap anymore, and it's not going to be easy for our patients to afford them in the COVID issues also. So straightforward, first drug down the line is Metformin, and ADA is very straightforward in giving the guidelines that unless there is a clear-cut contraindication, you are going to give Metformin with your insulin. How does that help? It still remains a first choice of therapy as a combination. There is a risk of very few side effects, and most importantly, minimal cost, and the pathogenesis of mechanism of action of Metformin does not need any explanation to this august audience. It will definitely help you bring down the HbA1c much faster when it's combined with insulin, and your requirement for insulins, whether it's basal premix or basal bolus, will definitely be coming down. And as you go on using insulin, like Dr. RK said, weight gain is the biggest issue, and the basic drug that you can always combine to negate that is with Metformin alone. There is no significant cardiovascular mortality problems with combining Metformin, and it will always give you a better glycemic control when it's combined with insulins. So it's often recommended as a first-line drug in type 2 diabetes, and I would dare say it is the first-line drug to combine with insulin also. And ADA 2022's position statement to be read out to this audience is it should be continued upon initiation of insulin therapy unless contraindicated or not tolerated for ongoing glycemic and metabolic benefits. Now, the biggest question that most people, especially in a very academic perspective, raise in insulin meetings is, why should you give a sulfonylurea with insulins? Even I myself was very hesitant to give sulfonylureas with insulin when I started off my practice, and the answer is basically it has a lot of extra pancreatic actions also. Of course, it will increase the risk of hypoglycemia. There is a chance that if you don't adjust the doses correctly, you might actually end up with severe hypoglycemias also, but that does not negate the benefits that you have with these data which come through. The fasting can be enhanced better with better control with safer, shorter acting sulfonylureas. The insulin dosage will definitely come down. The only concern that we should be bothered about is the weight gain issue with combination of sulfonylurea and insulins. As I again mentioned, hypoglycemia is something that we need to be a little worried about, and when you're adding with insulin, because insulin is a very broad topic to just say you add sulfonylureas to all your insulins, you have to look at the subset of patients who you are going to put sulfonylureas, because they have to have an adequate endogenous insulin secretory reserve to have any sort of a benefit from adding a sulfonylurea. If your patient is willing for only one insulin and you're thinking about either a basal or a co-formulation, and you have very high A1Cs, the drug of choice to add with that insulin regime will always be a sulfonylurea. Now, what about alpha glucosidase inhibitors and insulin? Alpha glucosidase inhibitors, as you all know, is basically to look at the postprandial control, and it's an alternative second line therapy when it comes to combination with insulins. And I see a lot of prescriptions now which are rationally combined with basal insulins and a combination of metformin and alpha glucosidase inhibitors. They give you modest HbA1c level benefits, but at the end of it, they also have shown to have benefits with the glycemic control. What about pioglitazone? Now, a lot of people are questioning the role of thiazolidinediones, but at the end of it, seasoned practitioners like the audience and the chairpersons here will always remember that this is a wonderful alternative second line therapy to overcome insulin resistance. Minimal cost, the only problems being the fact that it shows some time for the effects to show because of the gene-based mechanism of action. It has significant benefits with HbA1c in the long run, and the pleiotropic effects on atherosclerosis are helpful, and most of the times we can reduce our insulins by almost 10% from the baseline. Now, the problem here with thiazolidinediones is basically a concern with heart failure and fluid overload. So, the risk benefit of bone fractures, adipogenesis and heart failure or fluid overload is something that we have to be very, very cautious about, especially in patients who are on insulin from our cardiac colleagues and extreme elderly people as such. Now, the fourth group, or the popular most or the pushed most molecule in the sector now, which is Dpp Four Inhibitors. It's an important second line drug, and it is almost matching sulfonylureas in the prescription audits that we do. The risk of side effects is extremely low, and there is significant improvement in A1C, fasting and postprandial. So these are among the very few drugs which has started giving you fasting and postprandial benefits. And there is a reduction in the insulin requirement. It might not significantly help you with the weight gain part, but it helps you without pushing the patient into further risk of hypoglycemia. So it is as expected going to help you with limiting the dose of insulins, no major risk of hypoglycemia, weight neutral at best, and it gives you fasting and postprandial control. Now, SGLT2 inhibitors, like RK sir told, it is the wonderful drug which is being promoted big time from the studies abroad for atherosclerotic cardiovascular benefits, HbA1c reduction, fasting, postprandial, all happening without hypoglycemias, and it will also help you reduce the insulin requirements also. Now, the issue here with SGLT2 inhibitors is whom do you select for SGLT2 inhibitors? The primary group of patients whom we are actually using SGLT2 inhibitors are obese patients, cardiovascular and renal patients, patients who have high insulin requirements and who have large glycemic excursions should practically be considered for SGLT2 inhibitors. What is the practical problem with SGLT2 inhibitors? We are all aware of the genitourinary tract infection part, but there is another part which is the euglycemic ketosis, which we have to be a little bit careful about, and you should be looking at patients who are very prone for ketosis as such. I'm not going to go into the mechanism of action because I have a timer right in front of me and I have 4 hours left. And the last and the significant molecule that is going to storm the market is GLP-1 analogs, whether it is injectables or orals, and they are again going to be wonderful drugs to be used with insulins as such. Now, this is a summary of all the slides that I put through, and this is all that probably the audience can go through fast. Metformin, you will continue to use it with your insulins unless there is a clear contraindication for same. Sulfonylureas, wonderful drugs with basal insulins or co-formulations. When you're initiating with premix insulins, watch out for hypoglycemia, but you can use it with the antipodal meal. It's not a Shashi Tharoor term, antipodal meal. I googled to find out what they meant by putting this on the slide. It's just the opposite of the meal with which we are giving the insulin. So if you're starting insulin with the breakfast meal, you can give the sulfonylureas with the night meal as such. Even if you're starting with other premix insulins twice daily, just watch out for the lunch dosages and make sure that there is no high risk of hypoglycemia that's going to happen. Thiazolidine it can be used with insulin, and total daily dose can obviously be brought down with that. But if there is an issue or a concern with heart failure, you will discontinue it. Alpha glucosidase inhibitors, they can easily be used with both types of insulins, whether it's basal or premix. Dpp Four, again, wonderful drug to combine. Only thing is, there is a lot of prescriptions where GLP-1 receptors are going alongside Dpp Four inhibitors. So do not use that if there is an injectable, or even now the oral GLP-1 receptor agonists are being used as part of therapy, because the rationale is wrong. SGLT2 inhibitors, they can be used with insulins for better control, and it helps us cover the ASCVD high risk score population. It will definitely help you reduce the insulin dosages, and GLP-1 receptor agonists can be used with insulins for better control. Obviously, the affordability issue is the only question mark over that. Nobody has doubted the rationale for using that with huge amounts of trial data to come out right up to the pioneer trials. Now, what are the strategies for combining? The basic strategies are divided into 5. One, you want to reduce the insulin resistance or the total dose as such. You want to minimize the weight gain. You can add metformin, alpha glucosidase inhibitors, and SGLT2 inhibitors. If you are worried about the hypoglycemia, metformin, and again alpha glucosidase inhibitors, or even a DPP4 inhibitor. If you are using a long-acting sulfonylurea, you have to make sure that it is used in the morning and not in the night for the peak action to set in and risk the patient for hypoglycemia at night. And again, the issue which I want to concentrate on is the cost. Insulin is not cheap anymore. So if you are actually having high doses of insulin, please calculate yourself before you prescribe higher doses of insulin. And it gives the patient and the provider some kind of a comfort if you can actually modify to a once daily insulin with a once daily combination of OHS as such. So I've stuck to the time. I still have 1 minute and 50 seconds left. So I hope I've covered the topic. We'll cover it in the next 5 minutes of discussions as such. Thank you.
Thank you very much, Dr. Deepu. You really did well as a one-down batsman. It was very crisp and very lucid. You elaborated on the combination therapy, elaborated on various OHS, and adequately covered the complications with regard to the drug combinations. One thing that is very certain is today diabetes is the most important topic in medicine. We physicians really survive besides treating fevers. It is 85% of the diabetics still come under the physicians. It is our duty to see that these patients do not go in for acute complications, that is hyperglycemic complications. At the same time, at best prevent or at least retard the progress into long-term complications with regard to the kidney, the eye, the peripheral vascular system, both micro and macro angiopathies. Here one advice I have is, we talk a lot about HbA1c. HbA1c really helps us in identifying the long-term complications. Given the point, on given day when the patient comes to your OP, it is always better to have a blood sugar estimation that will determine whether acute complications are there. Having said that, all of us elaborated on the pathophysiology of diabetes mellitus, be it insulin resistance or insulin beta cell depletion. Beta cell depletion is a relentless process that will happen sooner or later. So you have been very good in elaborating the combination method. Only question is when to start insulin therapy. That's a very difficult question to answer. Nevertheless, with beta cell failure taken into consideration, sooner or later we'll have to go in for insulin at one point of time, at some point of time. I don't want to elaborate much more. I want to invite comments and questions from the floor. He'll be very happy to answer your queries. Please come forward.
You opened with metformin. I congratulate you. I want to know whether you use simple metformin or sustained release metformin in combination with insulin. Kindly clarify. And number two, before surgery, a physician is supposed to stop metformin at least 2 days for fear of lactic acidosis. During my 52 years practice after my physician MD, I have never seen a lactic acidosis. Can you clarify it?
I myself shouldn't be saying that I have 52 years anyway. I have 14-15 years and I still haven't seen the lactic acidosis which is looming. But the problem is there is an issue of litigation also around the corner. So I don't want to be left stranded at 15, not reaching 50. So I would rather stop it myself also. Second question about immediate release and sustained release. Immediate release has its own role, sustained release has its own role. It depends on where you are combining it and in what time of the day you are starting it. So both have its own advantages and both have its own disadvantages. So I think no, there are roles for either of them, sir. If you are putting it in a sustained release format in a single dose, that's fine. But if your patient is willing to take more number of oral anti-diabetic drugs and you can split it alongside, that's fine. But there are a lot of patients who do not tolerate sustained release metformins themselves. And there are times when you will have to put simple metformins morning, afternoon and night. There is nothing wrong with that. And besides the fact that it is much more affordable for most of our patients. A lot of our patients get this from the public sector funding, your nearby PHCs and things like that. There's nothing wrong with that.
In the practice I have had, the difference between a sustained release metformin and the other things.
Yes.
Start the treatment with metformin, I think that it will be better to start with a sustained release preparation, because as far as patients is concerned, it seems that they tolerate it much better. Number two is you talked about 48 hours stoppage of metformin. I don't think it is nowadays being practiced. Many, unless it is a major surgery, they stop only the night before the surgery. So, MIMS index, I know practically I have seen, because I have seen many surgery patients coming, and I don't think that there is a dictum that it should be stopped 48 hours before. And lactic acidosis, as you have said, I don't think none of us have seen a lactic acidosis with metformin. That's my practical experience.
Are there any more questions? Hello?
Regarding the hemoglobin SbA1c, many of the time I have seen SbA1c is normal, but fasting and PPGs are high. What to do in such cases? We have to treat or not?
No, there has been a lot of overemphasis on HbA1c. HbA1c could have been the result of a 3-month, period where the blood sugars must have been very high, and the present HbA1c may not reflect the given day's blood sugar. That's why I said that it's always better to check that given day's blood sugar and give importance to that. Don't blindly believe in HbA1c. I think we have so many more.
മലയാളത്തിൽ പറയാണ്, ഒരു സർജറിക്ക് ഒരു പേഷ്യൻ്റ് വന്നിട്ട് ബൈ ഗോഡ്സ് ഗ്രേസ് ഐ ഡിഡ് HbA1c. സർജറി കഴിഞ്ഞപ്പോൾ പറഞ്ഞു ഇത് മരുന്ന് കൊടുത്തുകൊണ്ടാണ് ഡയബറ്റീസ് വന്നതെന്ന് പറഞ്ഞു. അപ്പോൾ ബിക്കോസ് ഓഫ് ദ HbA1c വിച്ച് വാസ് ഹൈ, I could convince the patients and relatives that the diabetes was there before surgery. So HbA1c will protect you in your cases if you do it before surgery. Definitely you should check, as doctor said, it is best to do both fasting, postprandial, and HbA1c.
Thank you very much. We have a long way to go, I think. Thank you very much, Dr. Deepu, for your excellent presentation and
Thank
for
you.
the good participation.
Thank you, Dr. Deepu. And that
May I now request Dr. Paul Puthooran to give the memento to the speaker, Dr. Deepu. And Dr. Rafiq Mohammed to present the memento to Dr. Paul Puthooran.
Thank you, Dr. Deepu and Dr. Paul, for a very interesting and active discussion.